So we have to be aware of low literacy or no literacy when we are providing information, when we are teaching our clients and our community members. We have to be aware of that everyone might not have the same level of literacy. So therefore, we will have to revise or excuse me, adjust the interventions and information that we are giving to our patients. There, you may encounter a defense mechanism. A patient might just tell you, "Hey, I don't like to read. Just tell me what I need to know." So instead of saying, "I can't read," then you may get that response because it's a defense mechanism. Or the person might say, you just demonstrated for me and I'll get it. But you do want that person to actually demonstrate it for you so that you can evaluate whether or not they understood what you actually taught. So the person might have low literacy or maybe actually illiterate, but you do want to be mindful of those responses where the person is not taking part in and they say things like, "Oh, just tell me what I need to know." We often deal with individuals and populations who are illiterate or who have low literacy levels. These individuals may be embarrassed to admit their reading deficit to the healthcare provider, and educators may try to appear to understand when they really do not. Some people might say, "Well, okay, yeah, I understand what you're saying," but then if you ask them to read something or to demonstrate something, they will not. So, of course, we want to establish that rapport, that trusting therapeutic relationship. So those individuals will feel comfortable in saying, "Hey, I can't read that. I need you to show me a video or some other way so that I can understand." Because we do want them to make an informed decision about things, interventions, and medications, whatever that intervention is. We want them to make an informed decision. Because we do know graduation from high school does not guarantee reading comprehension. So, we want to be mindful of that when we're providing resources that are in writing and things like that. When a patient lacks self confidence, we want to explore the patient's feelings. We want to ask those purposeful questions so that we can get more information so that we can better provide and be of service to our patient. So if you are trying to get the patient to be more responsible and take ownership of their care, for example, if you have a new diabetic or a person that is a diabetic and their caregiver has informed you that they are just stressed to the max. And one of the tasks that the caregiver is doing is administering the injections to the patient. It could be, whomever, their parent, their child, their spouse, but they have confided in you and saying, "Hey, if such and such would just give their own injections, that would help me out a lot." And so that's the conversation you can have with your patient and ask those purposeful questions, asking what bothers you, most about giving yourself that injection. It may just be the fact that they are just uncomfortable with that procedure. It could be that they just don't understand. It could be just that they need to practice. And we can use oranges, we can use stuffed animals, but ask those purposeful, open ended questions so that you can get more information from the patient so that you can help them um, take part in their care. So when we talk about discharging, when we're admitting people to the hospitals, discharge begins at admission. When that person is deemed going to be admitted, all the different people from the teams try to see what their roles are and what can they do so that they can have that person in the hospital for as short as time as they can. We don't want to prolong the process. Now, we don't want to just push them out on the streets either, but we want to Begin discharge upon admission. Go ahead and be looking at those resources, that equipment that they might need. They might need home health. And sometimes, depending on which area they live in, you may have to reach out to more than one agency to get all of those things coordinated. So discharge begins up on admission. If you think the person is going to need equipment, and if that person lives in a rural area, how is that equipment going to get to that person's home? The caregiver might have to get someone else to go pick up the equipment. Things might change, but the whole point is that discharge process should start upon admission. Well, I spoke earlier about taking care of the client that has a terminal disease process. So things that we want to give priority to, we want to maintain the client's dignity and self-esteem and make the client as comfortable as possible. The nurse needs to focus on the needs of the client. You want to keep the client comfortable, maintain dignity and self-esteem. Although we need to also try to control their pain or lessen their pain. Sometimes people are just never pain free. It is not necessary to keep clients sedated so that they are unaware of what's happening, because you want the client to be able to interact with their family members and make decisions because it is their care. Family needs are important, but the client needs are the most important. So again, we want to maintain the client's dignity, self-esteem, and keep the client as comfortable as possible. Making decisions for the client and family removes autonomy and decision-making from the client and the family, who are already experiencing feelings of loss of control in that they cannot change the process of dying. So they're already feeling, some type of way because they can't control what's going on. Encouraging discussion of feelings is likely to enhance communication and would not require further assistance. Spiritual practices give meaning to life and have an effect on how people react to crisis. And we talked about the parish nurse. So we do know that the use of methamphetamines is on the rise. So you need to know when in the event that you need to seek emergency services. When do you need to call the ambulance? When do you need to call or dial 911? When that person's heart rate is really rapid, above 100, and they spike that temperature, they have that high fever. Methamphetamines or meth is an easy to make street drug that users swallow, smoke, snort, or either inject. Like amphetamines, meth is a stimulant that creates an immediate high that fades quickly. Because of the fading, users may take the substance frequently, trying to get that same high, which can lead to an addiction. The physical effects, they really are similar to cocaine. They include increased breathing, rapid heart rate, high blood pressure, increased body temperature, and this is when you should seek out emergency services or call the ambulance. Blood alcohol concentration is determined by the concentration of alcohol in the drink, the amount of alcohol in the drink, the rate of drinking, like, this is a drink just here and there, or they just go put them down. The rate of absorption. We do know that if a person is eating while they're consuming alcohol, the rate of absorption is slowed down. The rate of metabolism and a person's weight and sex. The amount of alcohol the liver can metabolize per hour is equal to about 0.25 ounces of whiskey, 4 ounces of wine, and 12 ounces of beer.